Hello and welcome back to Pathways in Pediatrics, the official podcast of the European Academy of Pediatric Societies, EAPS. I'm your host, and I have to say I am still buzzing with energy from our time in Lisbon.
It was an incredible few days, wasn't it? The EAPS 2025 Congress was just massive. Such a brilliant mix of people, from clinicians to researchers, all there, in person and online. I'm your co-host, and I'm definitely ready to unpack it all.
And for this episode, we're doing something a bit different. Instead of one track, we're going to look at a huge theme that just wove its way through the entire Congress: infectious diseases and immunodeficiencies.
It really did. It felt like every session you went to, from morning rounds to the big debates, people were talking about this intersection. It's not just about the bugs anymore. It's about the host.
Exactly. So our plan today is to take you on a bit of a journey through some of the real standout sessions on this theme. We're going to try and connect the dots.
Right, from emerging viruses and tricky ER diagnoses, all the way to the genetics that decide who gets sick, and finally how we can protect them.
We've got some amazing stuff to cover. We're talking stealth bacteria in bone infections, why a perfectly healthy kid might get severe encephalitis, and some really game-changing updates on maternal immunization.
So let's just get right into it.
Starting at the frontline emerging infections. The morning rounds session was packed, and Connell Watson's talk on RSV and influenza was a big reason why.
Oh, absolutely. This was so important for thinking about future winters. He pointed out this significant shift in the flu landscape. We talk a lot about H1N1, but he said we're really seeing a move to H3N2 dominance.
And it wasn't just any H3N2, right? He got super specific.
He did. He flagged a subclade called J2.4.1.
J2.4.1. That sounds like a password you'd forget immediately.
Right. Well, in a way, it's like the virus updated its password to get past our defenses. And the way they figured this out was using something called ferret assays.
Ferret assays, you mean, with actual ferrets.
Yes, exactly. It sounds old school, but they're the gold standard for human flu. So, Watson showed that this new variant had reduced neutralization in the ferrets against the current vaccine.
Okay, so in plain English, our current vaccine might not recognize this new version of the virus as well as we'd want it to.
That's it, precisely. The virus has changed just enough. He mentioned early epidemic activity in places like Japan and England, especially hitting school-aged kids, so it's definitely something to watch.
But it wasn't all bad news. He had a massive win to share on RSV, didn't he?
He did. This is where it gets really exciting. He highlighted the UK's maternal RSV vaccination program, which started in September 2024. They've given over 330,000 doses.
Wow, that's a huge number of pregnancies covered.
It is, and the data coming out of Scotland and England is showing greater than 80% protection in infants under 3 months.
80%. That is a game changer. If you work in a pediatric ER, that changes your entire winter.
It completely shifts the landscape of bronchiolitis. It's fewer babies on high flow. Now, he did note that as we suppress RSV, other viruses like rhinovirus might fill the gap. But preventing severe RSV is the huge win.
Absolutely. Okay, so speaking of sorting things out in the hospital, let's pivot to a clinical mystery that Katerina Gouveia talked about: acute bone and joint infections.
This was a fantastic session. She really focused on a stealth pathogen, Shigella kingae.
I feel like we keep hearing more and more about Shigella. Why is it so sneaky?
Because it just flies under the radar. Gouveia explained it's a major cause in kids under 5, often after something as simple as mouth ulcers. But the real issue is the lab work. Your CRP, your white count, they might not be sky high like you'd see with Staph aureus.
So you've got a toddler with a limp, maybe a low fever, and the bloods look okay-ish. That's a really dangerous spot for a clinician to be in.
It is. You might be tempted to call it a sprain. And she was so clear about this. If the ultrasound is inconclusive, you must do an MRI. You just can't rule out osteomyelitis without it in these young kids.
And the treatment is also changing, isn't it? We're not keeping them in for weeks of IVs anymore.
Right. The less is more approach is really taking hold. She talked about shorter 5E courses, just 2 to 4 days, and then switching to oral meds as long as the child is getting better.
That makes such a difference for a family.
Huge. And for Shigella specifically, it's resistant to some common antibiotics, but very sensitive to cephalosporins. So if you find it, you can treat it well and get them home.
Okay, let's move from the bones to the brain. This next part of the Congress was, frankly, a little terrifying. We're talking about acute febrile encephalopathy.
It's just such a high-stakes situation. Jane Hassel's talk was brilliant. Her big headline was that a negative CSF and normal imaging do not rule out an infection.
Which is every clinician's nightmare. You do the TAC, you do the scan, they both come back normal, but the child in front of you is still really sick.
Exactly. She used TB meningitis as the classic example where the microbiology is often negative. You just have to treat empirically based on clinical scores.
Yeah.
She also had a great pearl about using aspirin to prevent strokes and TD vasculopathy.
But then the conversation took a turn. Taisar Mong and Yale Cohen basically came in and said, okay, but what if it's not an infection at all?
This was the big paradigm shift. Autoimmune encephalitis. Thijs Armand focused on NMDA receptor encephalitis, which is the most common autoimmune type in kids.
And what does that look like?
Well, it changes with age, which makes it so hard. In teenagers, you see psychiatric symptoms. In younger kids, it's more movement disorders and seizures. And here's the craziest part. It can be triggered by a virus.
Wait, so they get a virus first, and then the autoimmune disease?
Yes, post-HSV autoimmune encephalitis. The child gets herpes simplex, you treat it, they seem to get better, and then weeks later they decline again.
And you just assume the virus is back.
Of course you would. But it's not. It's the immune system overreacting to the initial infection.
That's wild. So you cure the infection, but you trigger the autoimmunity.
Right. And then Yale Cohen introduced another one, MOGAD, or MOG antibody-associated disease. It presents differently, more like ADEM or cortical encephalitis. The takeaway from both of them was that Mayer-Nagek and NMDA testing has to be routine now. You can't just look for bugs.
And while you're waiting for all those fancy antibody tests, Simon Nidell gave the PICU perspective.
Yes, his whole focus was neuroprotection.
Yeah.
While everyone else is playing detective, your job in the ICU is to buy time, protect the brain, manage blood pressure, prevent hypoxia, stop that secondary injury.
So we've looked at the bugs in the brain. I want to go deeper now to the underlying code, the why. Why does one kid get a sniffle and another ends up in intensive care?
This was the central question of the immunodeficiency sessions. Per Siller-Pallison gave the emergency room view on inborn errors of immunity, or IEI.
I think many of us still have that very old-school bubble boy image in our heads.
And it's so much more complex. He said there are now over 500 recognized disorders. And it's not just infections, it's autoimmunity, it's inflammation. His key message was that every ER visit is a chance to spot an undiagnosed IEI. Look for the unusual.
Speaking of the unusual, Roger Kuloburn-Oriel's talk, it completely blew my mind. He talked about the healthy child paradox.
This is where it gets so fascinating. He explained that some genetic defects are incredibly specific. They might only cause a problem with one single pathogen.
He used that herpes simplex example again, didn't he?
He did.
Yeah.
A child could be totally healthy, fight off every cold, but they have a defect in their TLR3 pathway.
TLR3.
Think of it as a specific alarm sensor for viral genetic material in the central nervous system. If that one sensor is broken, the brain has no defense against herpes simplex. So an otherwise healthy kid gets devastating encephalitis.
It's terrifying. And then he brought up this other concept, phenolcopies.
Yes, this is amazing. A phenolcopy looks and acts like a genetic defect, but the DNA is fine. The problem is autoantibodies.
So the body is blocking its own processes.
Exactly. Like jamming a radio signal. He used the example of autoantibodies against interferons, which are the body's alarm bells for viruses. If you block your own alarm bells, you get severe viral pneumonia, which we saw in some severe COVID-19 cases. It looks genetic, but it's autoimmune.
Incredible. And just quickly, we have to mention Michael Kirschvink on the complement system.
Right, the complement system. He called it a double-edged sword. It's vital, but when it's dysregulated, it causes huge damage, like in HUS or lupus.
And he had a really practical tip, didn't he, about the lab work?
The most practical tip, complement is so unstable. If you draw the blood and just let it sit there, it activates in the tube.
So you get a false low reading.
You do. You have to cool the sample immediately and spin it down fast. A simple logistical thing, but it makes all the difference for getting the diagnosis right.
Okay, let's take a breath. So you've diagnosed the bugs, mapped the brain, sequenced the genes. How do we actually protect these vulnerable children? Let's talk vaccines.
A very tricky area. Philomene Herring took us through the European guidelines. The golden rule is about live versus non-live vaccines. For a child with a severe T-cell defect, live vaccines are dangerous. They can actually cause the disease.
But for other kids, it's different.
Yes. For those complement deficiencies we just talked about, live vaccines are generally safe. The real priority for them is boosting protection against encapsulated bacteria, like meningococcus, because that's their weak spot.
Ian Clara Pasfay-Barb raised a really common issue, the rituximab problem.
Yes, rituximab. It's a drug that depletes your B cells.
And B cells are what make antibodies.
Right. So if your antibody factory is shut down and you give a vaccine, nothing happens. The order goes in, but no product comes out. The vaccine just doesn't work.
So what's the strategy?
Vaccinate before you start the drug, if you possibly can. Postfia Barbie really stressed that. If you can't, you have to wait for the B cells to recover, which can take months.
Zooming out from the individual patient, Beat Campman gave a really powerful talk on maternal immunization.
This brings us full circle, back to the RSV story. She described it as a transplacental gift. It's about bridging that vulnerability gap for the newborn.
And it's moving beyond just flu and pertussis now.
The horizon is expanding, absolutely. She was talking about vaccines for Group B strep, which would be revolutionary, but also for emerging threats like chikungunya. Her main point, though, was about trial design. We have to include pregnant women in trials early on. They can't be an afterthought.
That's a perfect lead into our final segment, because we've talked so much science, but we need to talk about the people at the center of it all.
Yes, the patient perspective session was so important. Johan Prevo from IPOPI, the Patient Organization for Primary Immunodeficiencies, he just put the scale of it into perspective. 20 years ago, we knew of about 120 PIDs. Now, it's 600.
600, that's overwhelming for a clinician, let alone for a family trying to navigate it.
It is. And his message was, nothing about us without us. Patients have to be co-designers of research. They are the experts in what it's like to live with the disease.
And Charlotte Angelhoff gave this very real-world example of what happens when that goes wrong, a study that had to be terminated.
A real cautionary tale. The science was sound, but the study was just too hard for families to participate in. The barriers were too high.
And her solution wasn't just about money, it was about communication.
Exactly. Using simple language, using visuals, meeting families where they are. She even mentioned using platforms like TikTok. If we want research to reflect real life, it has to be accessible to people living real lives.
So if we bring it all together, we've gone from a tiny variant in a flu virus all the way to the genetic code of a child and then to the smartphone in their parent's hand.
It really shows how the field is moving. We're getting away from that one bug, one drug approach. The theme at EAPS Livman was clearly a move toward precision medicine. The specific viral strain, the specific host genetics, the specific timing of a vaccine.
It's more complex, but it's also so much more hopeful. We have tools now, the MRIs for Kingella, the antibody panels, the maternal vaccines that we just didn't have a few years ago.
And that's why we come to these congresses, right? To share these tools, debate the protocols, and ultimately improve the pathways for our patients.
Well, that brings us to the end of this episode of Pathways in Pediatrics. We really hope this journey through the infectious diseases and immunodeficiency scheme has sparked some ideas for you.
Thank you so much for listening. It's always a privilege to explore these topics. And please remember, the conversation definitely doesn't stop here.
That's right. We look forward to continuing it with you in person. Mark your calendars for the next EAPS Congress in Athens from the 24th to the 27th of September 2026. Until then, stay curious.
Goodbye, everyone.